So there can be two scenarios when a patient comes with a thyroid nodule, and we are evaluating the same as a routine thyroid nodule evaluation with thyroid function test, ultrasound, and FNAC. And that FNAC reported to be a medullary thyroid cancer. Or the second scenario, patient is referred or patient is coming with a FNA report of medullary thyroid cancer. So we have to do a ultrasound NEP. We should measure the serum calcitonin, CEA, and we should look for DNA analysis for red germ-like mutation. I'm coming to each of them. So first, the clinical presentation. So patient usually can present with a thyroid nodule or a lymph node swelling. So most of the 50 to 75% of the cases at the time of presentation itself, there is chance for lymph node metastasis, and around 10 to 15% patients will be reporting with a locally advanced disease with dyspnea, dysphagia, stridor endo. And in 10% of the patients, there is chance for distant metastasis at the time of presentation. Other symptoms will be related to the ectopic hormone production from the seed cells that may cause diarrhea, facial flushing, and Cushing syndrome, and other endocrinopathies. These are rare. So coming to the imaging, so ultrasound should be performed in all patients with medullary thyroid carcinoma, which will be helping us to assess the local as well as regional disease. The additional imaging will be based on the calcitonin level. So extensive neck disease, calcitonin of more than 500 picogram per ml, regional or distant metastasis, all these warrants an additional imaging. So calcitonin of more than 500 actually suggestive of local or distant metastatic disease. So according to the site, we can do a contrast enhanced CT of head and neck and chest, and three-phase contrast enhanced multi-detector liver or contrast enhanced MRI of the liver to rule out liver mets. And if we are suspicious of bone metastasis, we can go for an axial MRI or bone ciligraphy. And the role of nuclear medicine imaging. Currently, these are the PET radiopharmaceutical useful for medullary thyroid cancer. 18-fluoro FTG, 18F DOPA, gallium-68 DOTA somatostatin analogs, and these are the main things. So PET-CT actually useful for evaluating the distant metastasis, and it is actually superior to conventional imaging. But it is not recommended for routine initial screening for metastasis, and the sensitivity of this PET scan is variable, and its sensitivity actually increases with the increase in the calcitonin level. So according to Andrade et al., the sensitivity became up to 78% when the calcitonin level was more than 1000 picogram per ml. This is the image showing radioisotope uptake in the thyroid lobe and distant metastasis in the vertebra. So these are the commonly used tracers: fluorodeoxyglucose, fluorine 18, and somatostatin analogs, gallium-68 DOTA peptides. So just briefly about the DOTA scan. This uses actually somatostatin analog, which is labeled with 68 gallium, which is based on the overexpression of somatostatin receptors on the neuroendocrine tumor cells. So this helps in detection of recurrent medullary thyroid cancer up to 63%. And this F-DOPA PET-CT, it is based on transmembrane amino acid transporter system, which is present in neuroendocrine tumor, which helps in detection rate of recurrent medullary thyroid cancer up to 72%. So we did an ultrasound or an imaging, and we can go for a fine needle aspiration biopsy, either USG guided or direct. So this is a useful and safe method, which has got variable appearance in FNA. Cells can be spindle-shaped, plasmacytoid or epithelioid, and it can be disc cohesive or weakly cohesive. And these epithelioid tumors can mimic follicular lesions in plasmacytoid tumors. These cells are usually exhibit a eccentric nuclei with a chromatin granularity, specifically known as salt and pepper appearance, which is typical of neuroendocrine tumors. And there will be amyloid, and this amyloid can be mistaken for colloid. Image showing finely stippled chromatin. This image showing eccentrically placed nucleus with salt and pepper chromatin, and the inset picture showing immunohistochemistry of calcitonin, positive for calcitonin. So the cytology criteria for medullary thyroid cancer, the dispersed cell pattern, azurophilic cytoplasmic granule, and eccentrically placed nucleus, and presence of amyloid. So this C-cell hyperplasia, this is the precursor form of medullary thyroid cancer. It is considered as precursor. So it can be diffused and indistinguishable from the medullary thyroid cancer. It actually represents clonal proliferation of multiple transformed progenitor C cells. So when we should evaluate a C cell hyperplasia, that is when more than 7 C cells per cluster, or complete follicles surrounded by C cells, or a distribution of C cells beyond the normal anatomical location. So normal anatomical location is at the junction of upper 1/3 and lower 2/3 on the lateral border. So any C cells beyond this is warranting a evaluation. So medullary thyroid cancer can be misdiagnosed as a plasmacytoma or sarcoma in a slide. According to the Strimboli's meta-analysis, they considered 15 publications. They found the FNA having an accuracy of less than 50%. So what they suggested is, and what they observed is, diagnostic accuracy can be improved with immunohistochemistry and doing a calcitonin analysis in FNA, fine needle aspiration washout fluid. So IHC, the specific markers are calcitonin, CEA, and then absence of thyroglobulin, chromogranin. Other markers will be positive are CK7, CK18, and TTF1. So this is a proposed histopathologic grading system for medullary thyroid cancer, published by Fuchs et al. This is based on mitotic index, mitotic count, and Ki67 proliferative index, and coagulative necrosis, graded into low, intermediate, and high grade. And this has shown providing an improved prognostic information. So according to ATA, any thyroid nodule of more than or equal to 1 centimeter should be evaluated with FNA according to the ultrasound characteristic. So if it is conclusive, as we already told, we should go for an IHC. So coming to the specific molecular marker, calcitonin. So it is secreted by C cells. It's a 32 amino acid monomeric peptide. It is actually product of post-translation processing of procalcitonin, which will be physiologically elevated in less than 3 years in males. And elevated calcitonin can be seen in other conditions like chronic renal failure, hyperparathyroidism, autoimmune thyroiditis, and other cancers. And heterophilic antibodies can cause falsely elevated serum calcitonin. And hook effect means there will be high levels of serum calcitonin in the body, but in the immunoassay will be showing low analyte levels. Carcinoembryonic antigen, which is again helpful for the evaluation of disease progression and also for monitoring the patients following thyroidectomy. False elevation can be due to heterophilic antibodies or other GI malignancy or GI inflammatory condition. So we should remember that we should do serum calcitonin and CEA basal levels concurrently. And the simultaneous elevation of CEA and calcitonin levels indicate disease progression. So if we are seeing clinically a progressive disease with the CEA increasing and calcitonin stable or decreasing, in such a scenario, we should suspect for a poorly differentiated medullary thyroid cancer. So the next one, in all medullary cancer, we should look for RET mutation. So many of us may not be knowing the full form of RET. It is actually rearranged during transfection. It is actually a proto-oncogene discovered by Takahashi in 1985. It is located on chromosome 10q11.2. It encodes for a single-pass transmembrane receptor of tyrosine kinase family. So depending on this, it is divided into medullary thyroid cancer divided into sporadic and hereditary. Most common is sporadic, around 75 to 80%. 50% of the sporadic cases carry somatic RET mutation. And hereditary carries germline RET mutation. So familial medullary thyroid cancer can be due to MEN syndrome or it can be due to familial medullary thyroid cancer. So multiple endocrine neoplasia type 2 is related to the medullary thyroid cancer, MEN2A and MEN2B. So MEN2B is associated with the 918 codon mutation, and it is aggressive variety, where medullary thyroid cancer will be associated with marfanoid features and mucosal ganglioneuromas. And MEN2A, there will be chance for pheochromocytoma and hyperparathyroidism in association with medullary carcinoma. So when to diagnose a familial medullary thyroid cancer with that is a non-MEN familial medullary thyroid cancer. So when there is more than 10 family members with a medullary thyroid cancer, with an affected member of more than 50 years, or the simple definition is presence of medullary thyroid cancer in at least 4 family members without any other manifestation of MEN2A. So when to evaluate for a familial medullary thyroid cancer. So when a young patient of less than 30 years presenting with a nodule with a diagnosis of medullary thyroid cancer, or a patient present with bilateral multifocal disease, or a patient giving family history of medullary thyroid cancer, or giving history suggestive of MEN2. So how to evaluate for a heritable disease? So we should evaluate by genetic screening, DNA analysis for red proto-oncogene mutation, and we should do a screening for pheochromocytoma with plasma-free metanephrine, normetanephrine, 24-hour urine metanephrine, and imaging depending on these biochemical values. So ATA has categorized the aggressive variety of medullary thyroid cancer into 3: highest, high, and moderate risk. Highest risk is, as I already told, MEN2B with RET M918T mutation. High risk is red codon C634A883F mutation. And the moderate risk is all familial medullary thyroid cancer other than MEN syndrome, and all other red codon mutations will be under moderate risk. So how to go for management of familial medullary thyroid cancer? So all patients presenting with the medullary thyroid cancer should be subjected to red proto-oncogene mutation analysis. If there is no mutation, no further investigation required regarding the familial thing. So if it is mutation is present, the subjects, all siblings and offspring of the patient should be tested for mutation. And prophylactic thyroidectomy, I'll be coming to that later, option should be given to likely candidates. So coming to proper topic staging. So staging T, N, M classification is actually similar to that of the differentiated thyroid cancer. T1 means tumor that is less than or equal to 2 centimeter and limited to thyroid. T2 is more than 2 centimeter but less than 4 centimeter in greatest dimension, which is limited to thyroid. T3 again divided into T3A and T3B. A means more than 4 centimeter and limited to thyroid. T3B is gross extrathyroidal extension, which is limited only to strap muscle. T4A is gross extrathyroidal extension beyond the thyroid capsule other than strap muscle, and T4B is which will be invading the prevertebral fascia, engaging carotid artery or mediastinum vessel. And then regional lymph node involvement is divided into N1A and N1B. N1A is central compartment and superior mediastinum. N1B is the lateral compartment and retropharyngeal lymph node. M0, M1 is showing any distant metastasis. So the prognostic staging, we can see differentiated thyroid cancer, it is based on the age, it is divided into 2. So less than 55 years, there is only stage 1 and stage 2, even if we see any metastatic foci. More than 55 years, so again it is divided into 4 stages, but again even if there is any metastasis, it is considered as 4B. So coming to the medullary, so any tumor of less than 2 centimeter without any node is considered as stage 1. Any tumor of which is limited to the thyroid or with an extrathyroidal extension only to the strap without any node is considered as stage 2. Any central compartment nodes, irrespective of the tumor size, considered as stage 3. So any gross extrathyroidal extension, irrespective of the nodal stage, considered as stage 4A, as well as any tumor, tumor of any size with a lateral compartment lymph node is considered as stage 4A. So stage 4B with any N is considered as stage 4. T4B with any nodal staging is considered as 4B, and metastasis is considered as stage 4C. So again the same. So stage 1 means medullary thyroid, which is of less than 2 centimeter and with no evidence of disease outside gland. Stage 2, tumor confined to the gland with an extrathyroidal extension only to the strap muscle without any lymph node. Stage 3 is nodal involvement only to the central compartment. Stage 4 means any distant mets or lymph node involvement outside the central neck. So about the management of patients coming with a FNA diagnosis of medullary thyroid cancer, after doing all the evaluation, if the RET is negative, we should look for the calcitonin value, and if it is less than 500, we can go for a total thyroidectomy, and neck dissection can be planned based on the ultrasound features or intraoperative finding. If the RET is positive, we should evaluate for pheochromocytoma and hyperparathyroidism. So pheochromocytoma, if present, should be managed before the thyroidectomy. If hyperparathyroidism is present, it can be managed along with the thyroidectomy. If in both the cases, RET negative and positive, if the calcitonin is more than 500, we should go for other imaging procedures that I have already mentioned. So coming to the lymph node and mets in medullary thyroid cancer. So if the lymph node and mets in central and ipsilateral compartment carries around 50 to 75% irrespective of the tumor size. So the surgeon can do an intraoperative assessment in case of an ultrasound negative neck. So it carries around 64% sensitivity and specificity of 70%. The relationship of base and calcitonin with lymph nodal mets. If the calcitonin is less than 20 picogram per ml, usually there won't be any lymph node mets. And if it is more than 20, lymph nodes in the ipsilateral central and ipsilateral lateral neck is possible. More than 50, contralateral central neck lymph nodes are possible. More than 200, there is chance for contralateral lateral neck nodes, and more than 500 means there is chance for upper mediastinal nodes. So the ATA guidelines on extent of surgery when a patient diagnosed with medullary thyroid cancer and USG is showing no nodes and no distant nodes, we can go for a total thyroidectomy with central compartment dissection. Again, this plan is changes according to the surgeon to surgeon, and the lateral compartment dissection is actually based on calcitonin levels. And if the USG is positive, showing any neck nodes without any distant mets, we can do a total thyroidectomy with central compartment dissection with a dissection of the involved compartment. Again, the contralateral neck dissection, lateral compartment dissection will be based on serum calcitonin, and it should be done if the calcitonin is more than 200. Again, another one pitfall of AJCC is AJCC, they classified the nodes according to the qualitative assessment that whether any central or lateral compartment is present. So here the ATA suggests is histopathologically we should classify into N1, N2 and N3 according to the number of lymph node. N1 1 to 10 lymph node, N2 11 to 20, N3 more than 20 lymph node, because these actually carries a prognostic implication. So in some cases, the patient will be having a gross regional lymph node metastasis and disease. But in such a cases, complete cure may not be possible. But even in that cases, we should try to clear the disease maximum as possible to prevent the risk of local recurrence. And we surgeons usually go for a compartment-oriented lymph node dissection. And if there is an extensive regional or metastatic disease, we usually go for a less aggressive surgery, that is function-preserving surgery. So when if this is a scenario when a patient comes with a incomplete thyroidectomy with hemithyroidectomy or a lymph node dissection, so when to do a completion thyroidectomy? If the patient is having a red germline mutation or the imaging is showing any residual medullary thyroid cancer or an elevated serum calcitonin, all these scenarios we should go for a completion thyroidectomy. And repeat neck dissection is warranted if the pre-op calcitonin is less than 1000 and pre-operate in the last surgery they dissected only less than or equal to 5 metastatic lymph node, and in such a scenario also we can clear we can do the node dissection. So if you are seeing a enlarged node, but the calcitonin is normal, means ideally no need for a repeat surgery. So about the follow-up, as this is a parafollicular lesion, no need of any TSS suppression in the follow-up period. And just like any thyroid surgery, we should monitor the calcium levels. So when we can see a medullary is biochemically cured medullary thyroid cancer. So when the calcitonin level on follow-up is less than 10 picogram per ml, it is considered as biochemically cured, and in such a scenario, 10-year survival rate is almost 97%. So coming to the topic of prophylactic thyroidectomy. So prophylactic thyroidectomy means we are removing the thyroid before the medullary thyroid cancer sets in, or before it is clinically apparent. So the classical progression of medullary thyroid cancer in a hereditary setup is initially there will be C-cell hyperplasia that will be progressing into medullary thyroid cancer, then progressing into locoregional lymph node, and then the distant mets. So the management of patient with a RET germline mutation, we should do a physical examination and measure the calcitonin and CEA. In children, the highest risk for MEN2B, that is 918 codon mutation, we should subject these kids at the first subject for prophylactic thyroidectomy at the first year of life, and they should be monitored with the 6-monthly calcitonin levels and ultrasound, and they should be screened for pheochromocytoma at the age of 11. And if it is meant to at a high risk, we should do a prophylactic thyroidectomy before 5 years. And if it is a moderate risk, we can actually wait for the thyroidectomy. So as I already told, if the pheochromocytoma is identified during the workup, it should be managed before the thyroidectomy. And if there is hyperparathyroidism, we can examine the parathyroid glands. If only the visibly enlarged glands has to be resected. If four glands are enlarged, we can do a subtotal parathyroidectomy or a total parathyroidectomy with autotransplantation. So this is showing the evaluation of patients following thyroidectomy. So post-thyroidectomy, we can evaluate with ultrasound, calcitonin, CEA, and TFT every 6 to 12 months. So if there is a calcitonin is normal or undetectable, we can do it every 6 monthly for 1 year, then annually. If it is less, calcitonin is detectable, but it is less than 150 means, and 150, and there is no evidence of persistent or recurrent disease means, we can again go for a conservative management with physical examination and ultrasound every 6 monthly, and we can look for calcitonin doubling time. If the calcitonin is more than 150 in a post-operative setting, that is during follow-up, we should go for other imaging modality to rule out metastasis and local recurrence. In case of recurrent and persistent disease, we can imaging. We can use nuclear medicine imaging with PET scan. DOPA PET has got a higher sensitivity compared to FDG PET CT, and which has got a sensitivity ranges from 50 to 80%. So it FDG PET scan is actually significantly correlating with the progressive disease, and if the metastasis or local disease is taking an uptake of showing uptake of FDG, it is actually having lesser survival it is actually correlated with lesser survival. Coming to the postoperative calcitonin level, it can be measured like calcitonin and CA can be measured 2 to 3 months postoperatively. And if the patients with detectable basal calcitonin or elevated CA may be followed if it is negative for imaging or patient is asymptomatic. In increasing serum marker situation, we can go for a frequent imaging. So if these patients are followed up, this persistent or recurrent disease is followed up with the RECIST guidelines, or if there is calcitonin or CEA is elevated, we can check at constant interval to check for the calcitonin doubling time, because it has got a independent, it is an independent predictor of survival. So coming to the treatment of patient with regional metastatic medullary cancer. So the first option is always next exploration, that is resurgery. So patients with persistent or recurrent disease which is localized to neck, we can do a thyroid, following thyroidectomy, we can subject to neck operation according to the findings. But there is no clinical trial available, but the long-term outcome has showed good results with the prevention of recurrence. So we usually go for a compartment dissection of the involved lymph nodes in the corresponding to the imaging or FNAC, and limited operative procedures like a resection of only the involved lymph node, that all should be avoided. So that's this one is any role for postoperative radioiodine. Actually, there is no role for radioiodine, so it is not indicated. Only in those cases with mixed histology, like with differentiated medullary with differentiated papillary or follicular, can be subjected for radioiodine ablation. Third one is we can, if the surgery is not possible, we can go for a external beam radiotherapy. So the role of external beam radiotherapy, the indications are gross residual disease, that is R2 resection or R1 resection, or the moderate high volume of disease in the lateral or central compartment with extranodal extension, and in unresectable tumors, in recurrent disease which is not amenable to surgery. Also in palliative cases also we can give radiation. So the SEER data had showed this external beam RT has no role in overall survival, but it has a role in achieving local control. So we postoperatively we give 60 to 66 gray for microscopic disease as an adjuvant radiation. In gross residual disease, can be treated up to 70 gray or higher doses. So chemotherapy, this is actually important in metastatic setting. So this topic will be better dealing in the next class. So no role for chemotherapy in the initial management. It is useful in unresectable or metastatic medullary thyroid cancer if the patient is symptomatic or patient is having significant tumor burden, or in a progressive metastatic disease. So basically, tyrosine kinase inhibitors are targeting both RET as well as vascular endothelial growth factor receptor. These are considered for systemic therapy. Vandetanib and cabozantinib can be used as a single agent first-line systemic therapy. This phase 1 trial has showed the safety of cabozantinib, and it is actually targeting multiple pathway of which is important in medullary thyroid cancer, MET, RET as well as VEGF. This slide showing peptide receptor radionuclide therapy. It is a recent advance which is based on somatostatin receptor expression on the neuroendocrine tumor, and which actually these receptors can be radio labeled with somatostatin analog, and the use of concomitant radiosensitizing agents like capecitabine can be used along. So here we use Lutathera, the lutetium-177 dotatate. So it is given via IV infusion, which will be concentrating in the neuroendocrine tumor sites, and this will be binding to the somatostatin receptor type 2, which will over the surface, and these isotope molecule will be internalized into the cell, and which will be delivering the radiation and that resulting tumor cell death. Briefly about ESMO guidelines. So ESMO again warranting preoperative ultrasound in all patients, and this is the ESMO guideline. So if the calcitonin is less than 20, they are actually giving an option of total thyroidectomy. Again, neck dissection may consider based on the surgeon's assessment. Calcitonin 20 to 50 means total thyroidectomy with or without bilateral central compartment dissection. If the calcitonin is 50 to 200, they advise total thyroidectomy with bilateral central compartment with ipsilateral lateral compartment of 2 to 4. And if the calcitonin is 200 to 500, of the range of 200 to 500, we should go for a total thyroidectomy, bilateral central compartment, and bilateral lymph node, bilateral lateral compartment dissection of at least 2 to 4. So if the calcitonin is 500, just like ATA guideline, we should look for other site involvement. NCCN guidelines, same thing. So we are looking as a workup, we are looking calcitonin, carcinoembryonic antigen, pheochromocytoma screening, the serum calcium to rule out hyperparathyroidism, screening for red mutations, and the ultrasound and other imaging accordingly. So if the tumor is more than 1 centimeter or bilateral thyroid disease, which patient should be giving an option, we'll be doing a total thyroidectomy with bilateral central compartment dissection. And therapeutic ipsilateral or bilateral modified neck dissection is advised only for clinically or radiologically identifiable disease in 2 to 5. And we can do a prophylactic ipsilateral modified neck dissection in case of high volume disease in the thyroid or gross disease in the central neck node. If it is the tumor is less than 1 centimeter, better to go for total thyroidectomy and consider neck dissection according to the calcitonin levels. So this medullary thyroid cancer, if diagnosed after the initial surgery, we should look for the red mutation and to follow up accordingly. And if there is red germline mutation, again we should follow up, as I already told, follow up with CEA calcitonin and pheochromocytoma screening and the regular imaging workup. So if patient is diagnosing with MEN2A or familiar medullary thyroid cancer with primary hyperparathyroidism or without primary hyperparathyroidism, so the primary hyperparathyroidism can be treated along with the thyroidectomy. So the follow-up, usually 2 to 3 months, we usually ask for basal calcitonin CA in 2 to 3 months time interval. So if there is nothing, no calcitonin or CEA detectable or within the reference range, means disease monitoring with annual serum calcitonin and CEA. If it is detectable, then we should go for a neck ultrasound first. And if the calcitonin is more than 150, we should look for go for other imaging modality with CT or MRI to rule out local or regional metastasis. And consider bone scan if we are suspecting any bone mets. So if there is any local regional recurrence, as I already told, surgery is the first modality. If the surgery is not possible only, we should go for external beam radiotherapy. That is to in unresectable situation. And systemic therapy considered only when the disease is progressively increasing or patient is symptomatic. So coming to the survival part, the 10-year survival as per Modigliani et al. Stage 1 carries a 100% survival and stage 4 around 21%. So the relationship of calcitonin doubling time and survival, as per Barbet et al., it was a retrospective study. They followed up around 29 years. So what they have shown is, if the calcitonin doubling time is less than 6 months, they got a poorer survival. It is for 5-year survival is only 25%. Or if the calcitonin doubling time is around 6 to 24 months, 5-year survival comes around 92%. But the 10-year survival is again only comes around 37%. But what they observed is all patients with a calcitonin doubling time of greater than 24 months, that is more than 2 years, were alive at the end of their study. Thank you.
Thank you, Dr. Indo. So training resume type of questions come.
Any comments?
Sir?
Dr. Sandeep, any comments?
Yeah,
She
yes,
made very good points and highlighted in many of these slides that medullary carcinoma does not respond to radioactive iodine. It does not respond to any conventional chemotherapy. TSH suppression is not required. I really like all those points which she has highlighted in many of these slides. And you should evaluate every patient for hyperparathyroidism and pheochromocytoma. And total thyroidectomy with central neck dissection indicated for all with medullary carcinoma thyroid. Very good points highlighted. But just one point I would like to say, if you diagnose pheochromocytoma, that should be operated first, then operating on MTC. Okay? And every hypertensive patient, just look for pheo and have an ultrasound abdomen. That is the minimum investigation. And of course, urinary catecholamine and other things, the workup for pheochromocytoma, if there is slightest suspicion. And if you diagnose pheo, you must operate pheo first and later medullary carcinoma thyroid. Okay, that is important.
Yeah, sir. I'd like to add a point. Indu has actually very nicely presented what all guidelines she could find from literature. But
Yes.
then what we find is that many a times there are practical issues in following these guidelines per se. Almost all these guidelines suggest testing of RET at the initial stage itself.
Yes.
We actually took our data of the past 10 years. We also have, similar to literature, around 5 to 6% of medullary carcinoma thyroid amongst all the thyroid malignancies. And then most of them didn't undergo RET testing. But what we did do was all of these patients underwent genetic counseling. And then, sir, like you said, we tested them to rule out any MEN syndromes, primarily to rule out the pheochromocytoma. We underwent the serum metanephrines as a screening tool, and if they were found to be elevated, we did further specific investigations. One another thing was that if the calcitonin, all patients after FNAC found to be medullary carcinoma, we did do calcitonin and CA, and if the calcitonin was found to be 500, like Indu said, they suggest disease beyond the neck, perhaps in the thorax or the abdomen. So what we do is, instead of doing the CT thorax and then bone scintigraphy, MRI of the abdomen separately, we just go for a PET CT actually. FDG PET we do at the initial sitting when a primary patient is being worked up for medullary carcinoma as a part of the metastatic workup. And then actually our patients, around 40 patients were diagnosed with medullary carcinoma in the past 10 years. 80% were diagnosed with FNAC itself, and they showed, most of them showed elevated calcitonin values. 82% of them had nodal disease, but then around 20% did have distant mets at the time of presentation itself. And then since the topic of metastatic medullary carcinoma has been given separately, we didn't dwell too much into it. We didn't go to the various multikinase inhibitors or the specific RET inhibitors that can be used in medullary carcinoma thyroid. What we do here currently, we are giving cabozantinib. We are offering as first line for in metastatic disease which cannot be operated. But this is one disease in which what we do feel is that if you can operate and at least debulk, that plays a role in at least prolonging the survival. So that ultimately the problem with all these kinase inhibitors and all that is that they develop resistance. So they have a shelf life. They don't act beyond a point. So if operation or surgery can be done, we would always suggest go for it first. Even if it is a bit morbid surgery. We recently did a patient in which Indu had assisted also, in which we had to do a thoracotomy, do a mediastinal clearance. But then if the quality of life of the patient, speech and swallowing more or less can be maintained, we would suggest go for a radical surgery and then start inhibitors. You can prolong it because ultimately they develop resistance.
I think time permits. I'll just narrate one incident. It was 2007. We didn't have PET scans and all scans, etc. We only had calcitonin, and we used to get the report after 7 days or so. I saw, I think 35 or 37-year lady, teacher by profession, and calcitonin levels were about 31,000. And then in those days, the PET scan had just started, and she went to some other place and got the PET scan done, and it showed multiple nodes in neck, multiple nodes in mediastinum, hilar area, small lung lesion, and abdominal nodes and even pelvic nodes. And I discussed the case with so many head and neck surgeons, including TMH and MD Anderson Hospital. And majority said she's not going to benefit. But one surgeon said, one from Tata, we must do a staged surgery. Neck first, and then you do chest, and then maybe abdomen and thorax can be combined, but staged surgery. And I did bilateral neck dissection, total thyroidectomy, quite bulky nodes are there. And I told her that for second surgery, I would like to see her after 4 to 6 weeks. She didn't come for 4 months. She was a teacher, she got engaged in her other activities. And when she came after 4 months, I got her calcitonin done. It had dropped down to 100. So I was a little puzzled that how can these lesions in chest and abdomen be metastatic disease? So then we investigated these nodes and found them to be sarcoidosis. So everything, whatever shines on PET scan is not cancer. That was the first lesson I learned. And I definitely did, at that time we were not doing EBUS, we were doing CT guided FNAC from the mediastinal node